All right. Hello, everyone. Welcome to another virtual shadowing session at Hearts for Health. Today, we're joined by Dr. Cirino, who is an author, speaker, and physician with specialty in infectious disease and public health. He's had 20 years of experience in practice, and he practices in a few settings, including as an infectious disease specialist, a public health officer, and just a great variety as a physician. It really just goes to show how you can expand your horizons as a physician and go beyond just the clinic. We're really excited to have you on. I believe this is our second session over infectious diseases, and we're excited to see a few patient cases, learn more about what we can do now as undergrads, as pre-meds and pre-health students. We'll be covering that today. As a few reminders for those listening in, for those who might be new to the virtual shadowing format, we have these sessions in place with different specialties and different speakers each time. Towards the end of this session, we'll have a Q&A, usually the last 10 to 20 minutes. And you are free to ask any questions in the chat. So those questions you put in the chat, we'll go through during that Q&A time at the end. To stay updated with future shadowing sessions, you can follow us on Instagram or join our listserv. Our listserv is open to sign up via either our subscription page at the bottom of our website. There's a subscription form, or you can email us to get added onto the listserv. If you have any questions, feel free to put them in the chat or email us. Either way works. But with that covered, Dr. Cirino, feel free to take it away.
Hi, I'm Dr. Cirino. Thanks for joining us. And for those that are looking on the YouTube, thanks for checking this out. I am an infectious disease physician, and I'm really happy to be able to present about my personal journey as a physician. And I am getting a book published in the near future. I'm aiming for sometime in the beginning of June, which will also talk about the journey of becoming a physician for pre-health students, for pre-medical students. And so I'm going to tell you a little bit about my journey. So I want to first tell you about my influences. My parents were very strong supporters of me becoming a doctor. I suppose they, in a sense, infiltrated me with telling me I want to be a doctor when I was a young kid. And then they told me that I had always wanted to be a doctor when I was an adult or when I was a teenager. And the truth of that, though, is that I was very attracted to science and health. And as I was finishing up my undergraduate degree in microbiology, becoming a doctor was also a pathway to ongoing education. And so it felt like the right direction. I also had a passion to some form of volunteer work or helping others. My mother was an RN she was becoming an RN while I was a teenager. So I did my studying at Miami of Ohio. I'm from Ohio originally, BA microbiology, and I went to medical school. I had a choice between osteopathic and allopathic schools, and I'll give you a little brief summary of the difference for those of you that are looking into medical schools and thinking about osteopathic. I'll give you some information. And then I did my Master's of Public Health while I was a fellow and resident at the same hospital at George Washington Institute School of Public Health. My training was, I did a transitional year in New York. Then I went over to George Washington, did my internal medicine residency, took a year with the faculty and then a year off where I was working at a American University Student Health Center. And then I came back and joined George Washington again for my infectious disease fellowship. As far as my development, I would say that after doing work as an infectious disease doctor for several years, switching over to primary care and back to infectious disease, I started thinking about ways to expand, getting information out to people. And it really took a lot of my training and a lot of my career growth really took me back to the behaviors that led to infectious diseases or other health problems. And so I have a very strong interest in neuroscience, and I started a health website, which I'll show you in one of the cases, called Your Health Forum, where I have more than a couple hundred articles on health and wellness, but not necessarily the ones that are just informative, but going back to learning about behavior. What are the risk factors for health issues? And then I have several children's books, and I have some future books planned. And I'll talk to you about some of the things that I did for my career. These are some of the books that I have here on the side. And there's a free book on my website called Peppy Finds His Way, which you can find. What is a career as a physician? Well, some of you are learning this from talking with other people. Being a physician, it means that there is always something to learn. So it is a pathway of forever learning. So if you enjoy a career that is continually stimulating and always something to learn, being a physician is a great match for you. It has job security. As long as we have health, we will have illness. And getting older is part of facing that and developing a pathway towards wellness and preventing illness. But there will always be job security. There's flexibility. There's flexibility in your schedule. There's also flexibility in the career pathways, including clinical, academic, research, industry, just to name a few. And I also think it's a neat field because it's a bridge to occupation and vocation. So it's not so much the idea that you're just putting in your time and doing work, but there's a vocational element to it. And I think some people say avocation, where it's even, there's a great way to kind of think about human beings and we always, when we deal as physicians, we're always dealing with life and death issues in many ways. So moving on. So one thing I will mention about is what is a DO versus an MD. In general, the fields have very much converged from where they began. There are more than 1 million physicians in the US, and about a little bit more than 1/10 are DOs. The ratio is between allopathic and osteopathic medical students is 3-to-1. There are 152 US MD schools and 38 osteopathic medical schools. Allopathic is a very generic term that is basically relating to modern Western medicine. And this also relates to the pathway of using research and technology to drive advancements. So very science driven, and there's many training programs in allopathic programs, including educational opportunities, clinical research, and much subspecialty coverage. Osteopathic began in 1892 by Andrew Taylor Still, who was a physician at the time, who kind of became disillusioned in the practices at the time that were somewhat destructive. There were practices such as bloodletting and arsenic compounds for various medicinal, which isn't really understood as being anything positive, but those were the practices back then. And there are 38 osteopathic medical schools now. The original was formed in 1892, Kirksville, Missouri. And we're talking about here, some of the elements include osteopathic manual medicine or manipulative medicine, OMM, and it's a very strong commitment to primary care. So a lot of osteopaths coming out, I believe somewhere in the 50% range, go out in fields of internal medicine and family medicine for primary care. So going back to just general medical school and beyond, I want to mention some studies suggest, one would ask, well, do I have what it takes? Or what is it? What does it take to be a physician? What does it take to be a medical student? And Koenig identified 9 core competencies, including a lot of these are very life skill related. So I want to reach out to those that are looking into becoming doctors, working on your life skills. So reliability, service orientation, social skills, capacity for improvement, resilience, adaptability, cultural competence, oral communication, and teamwork. I do want to underscore the importance of communication and active listening. It can mean a lot when you're working with a patient who has a concern. And it's very important to look at the patient's concern as, pretty much carte blanche, legitimate. This is a legitimate concern. And the understanding of compassionate listening, active listening, helps to build a bridge between the speaker, the patient, and the listener, the doctor, and certainly also these active listening skills of trying to understand and hone in on what that process may be. And a lot of, I think Osler mentioned a nice quote is, listen to your patient. They are telling you what is causing their problem. And many of our conditions in later reviews, 75% or 80% can actually be identified, even higher than that, by just listening, by skillful listening. I also want to speak to one thing that I think probably is very legitimate, even to students in college, is this idea of burnout and workplace demoralization. Burnout essentially relates to a feeling of this kind of overburdening in one's work. It can be a depersonalization, a lack of efficacy, what you're doing, is this really helping, and just general exhaustion. Factors that contribute to burnout, and I think there are people, I think that there are people that can work on their resilience skills. I think everyone, and but I think when it comes down to it, it is not an individual's responsibility completely. It's also the workplace. So we're talking about workload, social isolation caused by work, a lack of voice or community, unclear expectations in work, and work-life imbalance. Some of those things that we do have responsibility and we do have, fortunately, control over, others we don't. Estimated about 50% of medical students experience symptoms of burnout. So this isn't something that just is reserved for physicians. In practice, in clinical practice, about 46 to 55% of physicians report burnout, depending on their specialty. And I would say that COVID-19 in many ways exposed burnout to the, even some of it which pre-existed COVID-19. Now, going back to a little bit of the DO tenets, I mentioned to you about the main differences. Now, Andrew Taylor Still, this is the schooling that I had. There are a couple of things, and a lot of these do relate to some of the Eastern thoughts about how the body heals. And I do want to say that when it comes down to it, we are coming full circle in understanding health. And I do believe we're going to be shifting to a new health paradigm, which is more comprehensive. A.T. Still brought out some of these notions. Some of these, again, go back to Physis, which is, or Physis, it's called, which is a Greek tenet about the body being capable of healing, and also some of the Eastern philosophies for health. So the body is a unit. The body is a unit of body. A person is a unit of body, mind, and spirit. It is capable of self-regulation, self-healing, and health maintenance. Structure and function are reciprocally interrelated, and the rational treatment is based upon an understanding of the basic principles of the body unit, self-regulation, and interrelationship of structure and function. And so taking this a step further, before we talk about my career specifically, which is infectious diseases, I do believe that, the more we learn through science, the more we're understanding the interrelationship between the brain, our environment, as well as the body. And I think, coming even from the fertilization of the ovum, there is already an interaction with the environment. Massive shifts of calcium come into the cell and start activating the genome for producing proteins. So we're shifting from this biomedical model to a biopsychosocial model, which is a more holistic approach to health. Certainly our medications have had shortcomings. There are, just to give you an example, for people who have high blood pressure, only 1 in 4 are actually controlled with medications. So it is more to it than just medications. Here's a problem, let's fix it. And relates to behavioral neuroscience, environmental factors, and past trauma. Technology is a driving force to health paradigms, and I think that's going to get us even further. Germ theory, for instance, and finding an infectious or cellular cause of disease, which definitely inspired me and developed in my career in getting into infectious diseases. we're going further in understanding, these theories of health. And it's not just, simply identifying a cellular etiology or a bacterial or other infectious cause. We know with COVID-19 pandemic that it wasn't just the virus that predisposed people to, why did some people develop severe COVID-19 and others did not? And we determined there were several risk factors, including high blood pressure, including diabetes, vascular disease. And so we also learned the other side of health. And then this idea of the biopsychosocial model, it was developed by George Engel in 1977, I believe, who is a pathologist and psychiatrist, which is an interesting combination. At one point, when I was thinking about infectious diseases, I actually was very interested in psychiatry. So there is an interesting correlation. Human health is intertwined with behavior and adaptations to environment. So you could imagine a pathologist looking at tissue of Crohn's disease, for instance, but understanding that there's certain predictive factors to our health that increase exacerbations of Crohn's disease. One of those studies that I think is really useful to bring up to the students include the ACEs study, which is an adverse childhood experience study published in 1998 by Felitti et al. And it basically shows that a childhood adverse events leads to chronic health conditions later on as adults, including various chronic conditions like obesity, high blood pressure, sexually transmitted infections as well, which suggest that in some ways adaptation to severe trauma leads to kind of a greater direction towards alcoholism, increased sexual activity, as one tries to cope to that behavioral stress. And I won't talk about too much about that, but I just wanted to bring that up to you. So what is the difference between generalist and specialist? So a generalist has a broad knowledge base and sees the big picture. And I want to say that it is not the exact opposite for a specialist. A specialist isn't just looking at the small picture. I think the specialist also looks at the forest and the trees. A generalist strategizes and monitors prescribing. This is a very important role as a generalist because oftentimes they're the point person, they're the goalkeeper, they're the person who decides upon, whether this actually does need further workup or whether the recommendations from the specialist apply to this patient, as well as looking at medications, ensuring that there's no problems with drug interactions, and certainly trying to encourage patients to understand that polypharmacy can be very harmful. A generalist mitigates harms and addresses behaviors. Behaviors are very hard to address in the clinic. And so certainly education is a starting point, but also understanding what the cycles are to chronic disease, for instance. That sometimes takes a little bit more than a clinic visit. More familiar with longitudinal history. That goes without saying because in really understanding a person's history through time, can we understand the development and the importance. Looking at a skin lesion through time, for instance. A specialist is focused on knowledge and heuristics. Heuristics are basically intuitive, quick decisions that we develop, just as someone would develop a skill set with playing a guitar or another, or working with tools. So too, physicians develop heuristics, which are more like intuitive, quick thinking, whereas the focused knowledge is more of a more logical thinking based on knowledge base. A specialist performs procedures in their respective discipline. So for infectious diseases, we don't perform procedures per se. I sometimes refer to an infectious disease specialist doing a chart biopsy, looking at the chart and doing a deeper comb through the information and deciding on testing. However, some infectious disease doctors do biopsies and other procedures. A specialist serves as a bridge between the general physician and patient for education, management, and a second opinion. Sir William Osler said, in truth, there are no specialties in medicine, since to fully understand the most important diseases, a person must be familiar with their manifestations in many organs. So, infectious diseases. This is an image here of some skin lesions that came after a family brought in a kitten to their family. This is a condition known as cat scratch disease. These are the primary lesions that then develop into lymph, that then activate our lymph nodes. So that's from Bartonella hensea. So as an infectious disease doctor, I did a couple extra years, 2 extra years of inpatient and outpatient consultative practice, which meant intensive review of patients. I was asked by internists, hospitalists who run the hospital could you see this patient for me and let me know what we need to do. Some of the infections were known and some were still for us to decide and to determine. And that is beyond the 3-year typical internal medicine program. Certification is one becomes board eligible after 2 years of fellowship. Some people may go on to do a 3rd year and sometimes even longer for research. And then after that, you pass it and you become what's called board certified after taking an exam. The work, as I mentioned, is performing a chart evaluation or biopsy to evaluate patients that when a condition is not quite understood yet, or something that has been defined and need further workup and follow-up. It is to assess and treat patients with various infectious diseases, and it is to interpret labs, radiology, and pathology in the context of infectious diseases. And so one of the things that infectious diseases specialists do in their fellowship is we review all the studies with the radiologists. And so in a way, we develop a skill set in interpreting radiology, particularly CT and X-rays, but also we review slides with a pathologist, as well as we review our microscopy. And to some extent, that is, as much as a fellow wants to pursue that. I had a colleague who would actually scrub into surgeries so that she can get a better understanding of what the disease looks like, actually physically looks like. In the setting, academic, private practice, hospital-based practice, public health, consultative for industries. And I also, I worked as a public health medical officer consultant for 2 years. I no longer do that for one of the counties. And I was basically asked, a lot of the care was through syphilis management, as well as tuberculosis program. But if there were other things like in the community, such as a measles outbreak that occurred before the COVID-19 pandemic in the community that I worked for, we went to the site and ensured that people were separated so that it would not spread to those that were unvaccinated. And this was a very interesting situation because this was actually an area where there were a lot of people that were unvaccinated. So I'm going to give you a case. So this is a 77-year-old who presents to the emergency department with a syncopal event. A syncopal event basically means passing out. There was an increase in lightheadedness and fatigue over the course of a few weeks in the ensuing weeks before. She had hit her head while dressing, which prompted an emergency visit. And there was also reported neck pain. Recently, there was a visit before, which included right flank pain in review of the chart. This was something that I had to do as an infection doctor, review the chart for when the prior history was. There's a urinalysis at that time that was negative, but a white count was 13, which is elevated. And there was a CT scan that showed a non-obstructing stone in the upper pole. So a calculus is a stone in the upper pole calyx, it should read. And then the patient also had significant constipation. When we evaluate patients, we do what's called a review of systems. And that's basically going through the systems It was otherwise negative. She did not really have any localizing symptoms at the time that she came to the ER and then hospitalized. There was no shortness of breath, no cough, nausea, vomiting, or diarrhea. Her past medical history, she did have a stroke about 5 years ago. There's been a prior history of falls as well. She did have some important history of multiple urinary tract infections, anxiety disorder, and a nerve problem, which is known as peripheral neuropathy. Usually it's caused by a metabolic concern like diabetes, but sometimes it can be what we call idiopathic, or we don't know the cause. No alcohol or smoking. The patient's blood work did show a high white blood cell count of 15,000. Also her hematocrit, which is an indicator of blood count, dropped. There was a sepsis workup that was conducted. She was admitted and started on IV antibiotics. She had some heart rhythm issues at the time called bigeminy, where every other beat there was a rhythm coming out of the lower part of the heart called the ventricular beat, or PVC. Blood cultures became positive, and they originally were noted to be strep viridans in 4 out of 4 bottles. Now, we do 2 sets, 1 anaerobic, 1 aerobic, 1 anaerobic, 1 aerobic, so 2 sets. And aerobic, is basically a higher oxygen level. Anaerobic is a low oxygen level, for those that may have not had the micro classes. And she had an echo done at the time, and that's a visualization of the heart valves. There was no obvious vegetation. That's a term that's used for growth, just like you would imagine vegetable. So no obvious vegetation, no obvious growth, which is what we can see with heart valve infections. A CT scan was negative. She had hit her head. And a CT of the neck was also negative, though there were some changes, possibly maybe some fluid overload, mild. She did feel better enough to be discharged, and she had another set of blood cultures that were drawn on the day of her release and sent home on antibiotics. However, her blood cultures grew positive again. And now, instead of strep viridans, they did identify this to be Enterococcus urinae, which is a very unusual bacteria. I'm going to go through a little bit with you, but it can be identified as a typical strep from the mouth. The discharged blood cultures became rapidly positive. Again, same organism. Patient was contacted by the hospitalist. I was informed as well. I said, she better come in. And she had still felt fatigue and persistent neck pain, but no fevers or chills. She returned to the hospital for further evaluation and treatment. Given the persistent septicemia, they went ahead and arranged for a transesophageal echo. Again, an echo is basically an ultrasound study where they look at the heart valves. A transesophageal echo is where a scope is put down that has an echo probe or an ultrasound probe on it. And essentially what we're doing here is we're getting a better view of the heart functioning because we're bypassing the chest and the tissue of the chest. So one note on Enterococcus urinae, this is a bacteria. This is how it looks on a blood auger. Blood auger is how it's grown. And basically the blood provides a nutrition for these types of organisms that don't grow as readily. It is a rare cause of infectious endocarditis, which is a heart valve infection. It results in a high rate of infection being transmitted to other parts of our vascular system. And that we refer to that as embolic events. Mortality rate is high. Risk factors include advanced age, history of urinary tract infections, which it seems like maybe she had, and maybe the urine culture was incomplete because she had a non-obstructing stone. Maybe there were some issues on the sampling, but certainly it seems like the writing was on the wall there. This is her echo, and I'm going to play it so that you guys can see it. What I'm pointing to with my pointer here is the valve, and I'm going to go ahead and play it again. You guys take a look at the valve. This is a leaflet, likely, that had basically ruptured. We have these leaflets called chordae tendina, and they're the leaflets that merge onto the valve. And sometimes that rupture can show up as this kind of large, what we call vegetation. One more time. Okay. So her hospital course. Now I see this patient. I'm doing an evaluation and I'm very concerned. And the timing is always a concern. It's hard to really pinpoint and timing. Definitely one would say that she's at high risk for getting a stroke. Anyways, the cardiac thoracic surgery team saw her, and since she was otherwise asymptomatic, they felt that there were no imminent risks. This was before I saw her. I saw her, and then I go into the dictation room to start dictating and reviewing her charts. And then suddenly I hear a nurse talking because she's in the room next door to me. There was an acute change in her mental status, and then she was having garbled speech and a left facial droop. Okay, I'm pointing to the right, and right-sided arm and leg paralysis. So whenever you see one side on the face and then one side on the body, it's very indicative of something going on in the brain. So a stroke. Code stroke was called, and she had a non-contrast head CT, which showed no acute findings, and what's called an angiogram of the head, which was done at the same time. That is where a contrast load is used, and it helps to refine the imaging and help the radiologist interpret better than just a non-contrast. A non-contrast is good for bleeding. So this is what her CT showed. It's very, to an unskilled eye, it could be very subtle, but I want to show you, I'll give you a little circle sign right there. And so this area is hypoperfused. Normally, this tissue is going to have a variable look like this, where it's a little whiter. That means the blood supply is coming through, so the x-rays don't pass readily. So in this area, the x-rays are passing readily. It's a hypoperfused area, or hypoattenuated area is another term. And if you were to do an MRI, it would show a mass amount of swelling and demyelination, which is it would be enhanced on one of the images of the MRI. So she had decreased perfusion of the left middle cerebral territory. That's the indication here, with an abrupt loss of opacification. And this was consistent with a stroke. So she was sent to an outside hospital who has the ability to do intervention. Unfortunately, they were not able to intervene. There was a concern that there was actually a rupture of the chorda tendina into the vascular supply in the brain. And so there was unfortunately no hope in sight for doing a procedure. So lots of resistance is how they described it when they were trying to do a percutaneous procedure to remove the thrombus in this case. And the thrombus is a clot. Percutaneous means through the skin route, going into the vascular supply. I'm going to step out. I'm going to step out from this, and I'm going to share with you two more things. Are we doing okay on time, Michael?
Yeah, we're perfect on time.
Okay. Before I get out of this, I'm going to leave a few messages for this last slide here.
All right.
So the next one is going to be a case here of an 18-year-old. This is my website, and for those of you that are viewing, I would suggest if you're curious about what it's like to be a physician, sign up on the website. I also have a free book to take a look at for health. So this is a case report of an 18-year-old with increasing neck mass. 18-year-old presents with a worsening neck mass over the last few weeks. 3 weeks ago, she had reported fevers, aches, chills, and a severe sore throat. A week before that, she was presenting into a clinic with a sore throat and neck swelling. At that time, the concern was with the severe sore throat, could this be mononucleosis or could it be strep, pharyngitis? Those tests were negative. She was diagnosed with a probable viral syndrome and was placed on a steroid, which helps with inflammation. It does not treat infection, though. So a Medrol dose pack was used. After some improvement, the pain and swelling and redness returned, prompting her to visit the emergency department. A review of systems, which is what I reported to you again, was otherwise negative. She did have, however, some problems with a little bit of breathlessness. So it was hard. I think it was the day of the ER visit, she had increasing shortness of breath. And there was a little bit of a rash for a few days 3 weeks ago. She did have some recent dental work as well. No exposure to tuberculosis. So there's her past history. These are her meds. She was on a prednisone taper. And her examination was significant for two things. I'll note to you, whenever we present her exam, it's to the attention to really review those vital signs. So no fever, temperature was fine. Pulse was a little low. Respiratory rate was 18. Pulse ox was 88%. A normal pulse ox is 95% or greater. And when you go below that, there's quite a disparity between the PaO2, which is the arterial pressure of oxygen. So that can be quite varied. And so when you see a pulse ox of 88%, that should sound an alarm, a red flag. Blood pressure is 105/68. So she was non-toxic appearing, but she did have fullness of her left neck and mild erythema. I'll show you the CT. There was some fluctuance, which is a feeling like you can press in, and it's kind of boggy type of a feeling. Mild lymphadenopathy or palpable lymph nodes below, and a mass in the left anterior cervical chain of lymph nodes. Her lungs were clear, and don't let that fool you sometimes. Sometimes a negative x-ray could mean more. So white count was 18, so it was elevated. And she did have mostly neutrophils. This is a type of white cell population that is caused by an acute inflammation or infection. Hemoglobin hematocrit was a little low. When the students become medical students and see ill people, most of the times those hematocrits drop a little bit. Anyways, nothing too significant. This is her CT scan. I want to point to what side is normal and what side is abnormal. This is the normal side. So when you see this is quite a large area, probably around, I would say 4 by 6 centimeters. And again, it's got that hypoattenuation look to it, which is different than the tissue around it. And that's suggestive of an abscess. So what were the most likely risk factors for the evolution of this process? So A would be the use of the steroid taper, 2, underlying viral syndrome per history, or a lamictal dose, which might have affected her immune status. The answer to that would probably be the steroid taper, but there was definitely underlying respiratory process that started. What studies are missing in this workup? And I said, look at the vital signs. So this is, I'm going to give you the answers, but it's sort of more of a kind of, walkthrough. Finally, or the last 2, why may she not have had a fever? And so the question to why she may not have had a fever is that she is on prednisone, and that is an anti-inflammatory. And she also, the other thing is someone could also be taking Tylenol, so it can blunt the fever. And finally, what is the likely diagnosis? So here's the gram stain, and there are some very small organisms here, and you can see, so these are kind of coccobacillary. Some of them can also be longer bacilli, and so I'm going to point to this. This is where the answer is. Okay, so the answer is Fusobacterium necrophorum. This is a normal flora of the back of the throat. That means that some people can have this as a normal bacteria of their throat. However, sometimes an infection can change the process, such as a viral infection, mononucleosis, pharyngitis, and it can sometimes lead to an overgrowth of this bacteria. And lead to a process that is very unique to this, this infection, including specific to Fusobacterium. And what it does is it causes a blood clot to develop in the venous circulation of the neck. It's the internal jugular vein. And that blood clot, as you can imagine, our venous supply goes to our heart. So that blood clot, some of those pieces are received. Most of the blood clot is a mixture of our own clotting mechanism with bacteria. And so those pieces get sent over to our lungs and cause pulmonary emboli. And I had already described to you what emboli are for the stroke. And so again, this is another embolic process. So it can cause lung changes. I want to show you, this is what an X-ray, I believe this was her X-ray. And so when you look at the, here's this is an example of what that pleural space is. A pleural space is a space that's aligning the lung. It is a virtual cavity. It's not usually filled. Our pleura produces fluid, very little fluid. I think it's, like 0.3 cc's per hour. It's a very small amount of fluid. But when there's an inflammatory process that holds it up, it tends to fill up. And so that's what we call a pleural effusion, or fluid between that space of the lung, the visceral pleura, and the parietal pleura, the organ pleura.
Dr. Cirino, I just want to quickly say, I'm not sure if your screen is sharing correctly. Right now it's paused on one slide. I think it's slide 19 that we see.
Oh, okay. So you're not seeing what I'm viewing right now?
No, I don't
Okay,
think so.
give me 1 second. Yeah, too bad. I wish I would have known. We'll get it now. Okay, I forgot that I have to go out and then get back in. Okay, can you see it now?
Yeah.
Okay, I'm so sorry. Thank you for bringing it to my attention. I'm just going to show you the mask. So did you see that, Michael, before?
I think the whole time we saw just the
slide I was left off on.
Yeah.
Okay, so this is the mass that I was talking about in the report. You can see it's quite a sizable mass. And then this is the gram stain. There are some of these, what we call bacilli. And then I'm talking to you about Fusobacterium, which is a bacteria that produces this process called Lemire syndrome. And this was her X-ray. And you can see here that's completely white out. And then this is the CT scan. This is a thickening of that space, just like I was showing you here in this image. And so this is basically a pus pocket or an empyema. And so this needs to be addressed not by just draining. It actually needs to be addressed by a video-assisted thoracoscopic surgery where a surgeon goes in and just removes that peel, washes it out, and applies a chest tube. And little by little that will heal, and then he or she can remove the chest tube. So the risk factors were the medral dose pack. The other study was the CT scan. In fact, I had a patient like this a year ago, and it was just a small, low oxygen level. I looked at her X-ray. There were some very subtle changes on the X-ray. I went ahead and ordered a CT, and sure enough, there were multiple pulmonary emboli, multiple clots, as well as a pleural effusion that wasn't found on the X-ray. So that's Lemire syndrome. All right, and then the final case. I'm sorry you didn't see did you see the echo result?
I believe.
Oh, that was on the first case. That's good.
Yeah, the very beginning we did.
Good, got that one. Okay, so the next one and the last one is, here we go. Okay, this is one that, let me see. Pardon me, I'm going to get the initial part of the case.
Take your time.
Okay, perfect. Here it is. So this is actually a different case. So this is the beginning of it. So the last case is a 51-year-old man with a worsening pneumonia while hospitalized. And so 51-year-old who had increasing shortness of breath, cough, and weakness over a period of a few weeks, no previous significant past history, low-grade fever, and works as a custodial worker and was subjected to a lot of secondhand smoke in the work, growing up. This is the initial X-ray. And so to take a look at this X-ray, you can see there's a lot of the X-rays trying to cross through. This would be the normal pattern of healthier lung. And you can see there's a lot of white showing up here, which is often a sign of a focal consolidation or density because of pneumonia. So the patient was initially placed on Rocephin, Levaquin, and doxycycline. These are 3 antibiotics that are often used for pneumonia. We would typically take a patient in and use Rocephin and azithromycin, or ceftriaxone and azithromycin is the other name for it. And then was also started on Solu-Medrol for several days. Initial sputum was normal flora, meaning we weren't able to capture an organism. I will say that the yields for sputum samples about 50%. So we still treat empirically when someone has this type of finding for the usual suspects, as it were. And most of the time we're talking about is Streptococcus pneumoniae, H. influenzae, M. catarrhalis, and being the main 3. Okay. Patient ended up having a bronchoscopy, which is a procedure where they stick a scope, which is a fiber optic piece that is small, that's just a very small caliber, so that they can visualize the bronchial tree, as well as take samples, including biopsies. And the patient had a bronchoscopy 5 days. The sample was negative for a fungal infection called pneumocystis. The gram stain did show few gram-positive cocci. Culture grew out yeast and normal respiratory flora. So even in that point, now this was a patient who had already been on antibiotics for several days. This is after the chest X-ray showed even worsening density, and there's even these kind of almost like leveling out findings. That is anathema to what a normal picture would look like in an X-ray. And so this translates over to a CAT scan that showed these findings here. And so this is what it looks like. Now, what this is there's parenchymal, there's normal lung tissue that's kind of shrunken in that area. And then there's this exposure of some thickening of the pleural area. Once again, I showed you what the pleural area was, with what looks like air fluid levels, grossly abnormal. So what is the process being depicted in the CT scan? And so the patient, so this is sometimes referred to as a bronchopleural fistula, which means there's a connection where there's some air that came out from the lung into the pleural space and some fluid from it. So basically it's like a more complicated pus pocket than the one we had before. So cardiothoracic surgery was involved, and there was an area of necrotic tissue in the setting of right lower lobar process in the thick pleural peel. So when they pull that tissue out, it's like a rind, almost like they would describe, like a rind from an orange. And this is called an H&E stain, or hematoxin eosinophil stain. And then this is what's called a silver stain. Now, a silver stain is very specific to the cell wall of fungal organisms. So if you take a good look at this, and I'm going to show you the higher microscopy, these are these little round bodies, okay? And then there's these little kind of areas that are kind of stretched out. Now, when you take a look at this up close, okay, does that expand it?
Yeah, we can see it there.
Okay, great. So what you see are these little round bodies and then these kind of spaces in between. Now, these are called pseudohyphae. Pseudo meaning false, hyphae are basically normally seen with fungi that are kind of thickened walls and branch out. And these are called pseudohyphae. These are created by yeast. Yeast do not form real hyphae. And so these are called pseudohyphae. You can see these little buds at the end of them, and this is a very typical appearance of a yeast. So a yeast is growing in this person's tissue. What is the name of the specialized stain? That's called a silver stain. It's used to identify the fungal cell wall. What is shown in this and is what I've described, and what do you expect the suspected diagnosis is. And so the answer to that is that this was consistent with yeast. And are you seeing this now, the answer part?
Yeah, we are.
Okay, perfect. So, so again, this was called a GMS stain, Grocott's methamine silver. And then in this case, we identified a Candida lung abscess. Candida is the same yeast that it causes yeast infections on the skin, athlete's foot. So that's what Candida is. All right, those were my 3 cases. I'm going to switch over to stop share and then get back on to finish up my slide. Is there an audience for questions?
So we have a few questions, and you can take as long as you like with it. If you want to wrap up in like 10 minutes, 15 minutes, however long.
I'm finishing up in literally 10 minutes and then, or 5 minutes, and then we'll just go ahead and answer the questions.
All right, sounds good.
Okay, perfect. So we'll go to this part. I'm going to re-expand this. And so this is what I'm getting into now more than I was as an infection doctor. I will continue working as an infection doctor, and I plan to do volunteer work in other countries too. But I do want to show you, these are the vascular beds of the heart, of the kidneys, and then I believe these are the bronchial beds of the lungs. And you can see a very interesting phenomenon. And this is basically in all living structures. And this is these branching processes. Now, if you think about it, the job of our cells is to maintain cellular respiration. Now, I don't mean respiration like breathing, of course, but the production of proteins. And so essentially every cell in our body needs the same amount of oxygen, nutrients. And so we need a vascular bed that will take us from a function, from a structure to a function. So ultimately, our blood supply takes the same amount of blood to every single tissue of our body, every single cell. And so when we talk about health, illness, and we talk about diseases such as chronic diseases, it's very important to mention about how our body interacts with the environment, because we go from the external, what we take in from the environment, which are things that we ingest, things that we inspire, the air pollution, organisms, including COVID-19, and then finally our injuries, whether it's a direct injection into our vascular system, like the patients that I see sometimes on wards who use injection drugs, or it's a direct trauma to our skin. I have seen infections in people who have blunt trauma, otherwise unable to see where the wound is. There's a bruise, but there's no break in the skin, who then develop a bacterial infection such as cellulitis. Anyways, with those four, and then the final one I think is the most fascinating, is I call it the fourth I. So we have injection or injury, we have inspiration, ingestion, and then impression. And impression is the kind of idea that our brain anticipates what the environment is based on its past experience. And in many ways, our brain can literally paint and develop a picture of a body pathology. Now, it seems like it would be almost a very unusual measure, but actually it probably happens more than I can describe. I've seen, occasionally I've seen patients who are catatonic, who are essentially, because of a gross traumatic response, develop into a reaction. Now, in many ways, health problems, including diabetes, heart disease, are a behavioral adaptation to stress. And so if you think about it, many of the things that we do we have coping strategies for stress. And I mentioned about the ACEs study with, the acute or the adverse childhood events leading to chronic diseases as well. And so in many ways, our brain, it's sort of the traumatic experience, some of which may not be abject trauma. It could be just a minimal process. For an infant, it's a big process. For instance, I'm hungry and I'm not getting fed. So the traumas may even precede our cognizance, our ability, our consciousness of it. In any event, it's almost like the brain sears an image of that trauma and then repeats an adaptive response to it, and sometimes goes through those coping mechanisms, which, as I mentioned about how the ACEs study relates to an increased risk of sexually transmitted infection, drug use, alcoholism, as well as diabetes, that we take our environment in differently after trauma. And now, not all trauma is the same, and not all people go through the same trauma, even if it is the same. And that's the fascinating part of it. It's not so much the trauma always, but it's the vessel that receives the trauma. It's the cues. It's the brain. If it's been, adapted already to higher rates of trauma, we've seen, there's associations with borderline personality and narcissistic personality in people who've had prior trauma. And then also those personalities increasing the rates of post-traumatic stress disorder too. So it's sort of a cyclical process. But there was an interesting study looking at the protein signatures in centenarians, suggesting that these people who are able to live to 100 years old are doing so one day at a time, one moment at a time. They are showing signatures that they are aging more slowly. Well, that in some ways, it kind of all makes sense. I mean, they're living past 100, but it also speaks to the fact that each of us have some relative control over our lifespan. And so I'm putting all those two concepts together. And that's what intrigues me now in my career. And it really comes down to the genomic presentation and regulation. So we're talking about not only the genome, but the epigenome. And so in many studies, when we think about much of our health being related, when we say, oh, it's related to genetics, well, 100% is genetics, but some people have the general notion that genetics is like, oh, we're doomed. It's just based on what we're given. And some of us are dealt a bad hand of cards. But genetic is also based on regulation of epigenes. And so we see an increased epigenetic changes basically occur because of lifestyle, because of not sleeping well, because of not eating well or not exercising, or also chronic stress. And so we do have some control over that. And I just wanted to share that with the medical students. I don't know if they had any introduction to that already, or the pre-med students. I am finishing up this book eventually. It's been about 1.5 years in the making. And I wanted to just bring this up to you. This was said by Thomas Edison many years ago. The doctor of the future will give no medicine, but will instruct his patient in the care of the human frame, in diet, and in the cause and prevention of the disease. And I believe we are coming to that point where, as individuals, we are all taking a greater initiative on our health. We are, after all, the vessel, of our health, and we are the sole responsible for our health. However, unfortunately, we are not always responsible for our environment and some of our circumstances until we can choose our environment and our circumstances. But I wanted to bring that up to the students. And then finally, if you want to reach out to me, this is my website. It's called Your Health Forum by drcirino.org. And then I have another website I just began. It's called tomorrowsdoc.com. This will be the one that's based on the book to come. And then you can reach out to me at Your Health Forum on Instagram, and Your Health Forum podcast, as well as my email. Should you have any specific questions about your career, I will be happy to do a brief review or about any questions you may have based on my experience. And that rounds off what I wanted to talk about today. I'm open for any questions.
Well, first of all, thank you so much, Dr. Cirino. I think that this is such a great presentation for not only like the details around clinical practice, but also insights that we can take away. You mentioned your book, pretty applicable to the population of pre-meds that are listening in, and pre-health students in general that are listening in. We do have a few questions we'd love to cover.
Sure. We'll keep it on this. Okay. How do I get into the questions?
Yeah. So I wanted to get, first of all, into the dual nature behind your service with public health and also infectious diseases. Past just a DO, you've also went on to include a MPH on your kind of resume of things in terms of education. What spurred that inspiration to go on and continue for a master's in public health?
Great, thank you. I think for me, and I think a lot of students will probably start seeing this as well, even in college, is that in many ways, your career is up to you. There used to be this kind of idea that you would just basically hang a shingle, do your private practice, or work with a group, and basically that's your career until you retire. And I think it's very important to mention that, becoming a physician is partly becoming myself. It's kind of going into that direction. I honestly wasn't convinced that, going in when I was younger, I was not completely convinced that it was the doctor that I needed to be or wanted to be. I also was very fascinated with, anthropology at the time, and doing some volunteer work in other countries. I'm an international file. I love to travel. So I think for me, when it comes down to the career decisions, I do want to let the pre-med students know that there is some more fluidity in career choices. And I would consider, now there is a little bit of sacrifice that you have to go through in medical school and in training. But they are a lot better. The situation, the environment, the training is a lot better than it used to be. Now that residency practices have caps to how many hours you can work, caps to how many patients you can admit. And so it makes it a lot better. But nevertheless, I mentioned about the burnout even already being seen in medical students. So a lot of this is really, the idea is that it was kind of my responsibility I took on to trying to figure out myself more. And while I was training as a resident at GW, they offered MPH training. And I was thinking maybe I want to get into preventive medicine after internal medicine. And there were some really great programs, Tulane, Johns Hopkins, and Emory, that were willing to take me in. And I at that time, I really didn't want to reinvent the wheel. And so I kind of decided to just take the courses I had already taken and then just put them all together, take some more classes and finish up my MPH at GW. And so that's where I did it. Why I did it is because I think my calling is more towards international health and working in sort of the realm of volunteer or medical missionary work. However, when you get married and settle down and start having kids, your career objectives change for the moment. But remember, you do have a say. And I always like to remind people that in some ways, we're only limited by our own capacity of what we can handle at the moment. And so I encourage all of you to look further. One of the things you could do is after you finish your training, think about this, is maybe save a day, a little kind of, Joker's Wild Day where you have a free day and you can decide what you want to do with it. And that's how I got into the public health aspect. Since I had already done my MPH, I had been in communication with a public health doctor on other cases of tuberculosis. And she had told me that, there's a job opening up in Marion County. They need a doctor for a day. And I'm like, okay, I do that. And so I worked with them for a few years until kind of the beginning of the COVID pandemic where they had to reassess.
So speaking of, you mentioned your work in terms of volunteering globally with medical missions. Speaking of that, I believe there are a few organizations that have that set up, like Global Brigades, to name one of them. For the students listening in, I think that they can also get involved. Do you know of any ways they can get themselves engaged in that field of work?
Yeah, I mean, the one group that I've been working with a lot, and I want to give them a shameless plug, is Refuge International. And they're out of Texas. And I really love the mission and the PA that started this. I started as a physician assistant, Debbie Bell, who went over to Guatemala and basically wanted to make those changes, following the thought of Mahatma Gandhi, right? Be the change that you wish to see in this world. And that's one of her quotes that she talks a lot about. But she set up a clinic there, and we take medical students. I've been on that trip 3 times now, and we often have large brigades, medical students as well as pre-med students. Anyone to help out. And so that was one that I've worked with. I've also worked with a group called, I think it was called MedServe or MedSend. I don't know if that name is the same as it is now. However, I was paired with a mentor who was an internist pediatrician, went over to Africa, did some work in the Gambia, and it was just an amazing experience. I think I would encourage any pre-med student to consider taking a trip, volunteer work. You can find these online, but and also in medical school, because I think once you start seeing how number one, how other places practice, but also number two, how people practice in disparity, you will be it gives you a better insight on how to practice and you use your skills of physical examination, of history. And also you'll see some really interesting pathology that people unfortunately have when they don't have medical care.
Yeah, that's a great point. I wanted to also touch on how having trained in infectious diseases, did that carry over to your work in public health? Do you think that infectious diseases is just a more fitting specialty when you're trying to get into the public health sphere of things?
Oh yeah, I mean a lot of well, I'll tell you, infectious diseases is definitely a lifelong career to be a specialist, meaning that there's plenty of work to do as a specialist. So essentially, the main job, like I was saying, is just reviewing labs and reviewing a patient's examination. So in a sense, we are a public health doctor to the one patient. And so yes, I think an infectious disease doctor could do those types of things. But I think the public health, which is more kind of the broad population health, is really essential in public health. And so I think it's important to mention that in many ways, being a physician is like being a public health doctor. Some countries actually put doctors in for an annual rural, like a rural year, where they work in a rural part and they work on the disparities of health there because they're the doctor. And in some ways, they're also the public health doctor too. So I mention that because there are a lot of job possibilities to be a doctor. There are clinical and non-clinical jobs. And so I think the public health part, that was a nice opportunity. I really enjoyed it. It wasn't completely where I was going in my field, but it was fascinating because of the outbreak investigation. It was to be able to participate and be a spokesperson for the community too was a very was a privilege that I was able to have, and I was grateful of it.
So you mentioned you practiced at George Washington, which is on the East Coast, and now you're in Oregon on the West Coast. Between practicing from one coast to the other, we hear that there's some differences with practicing in different environments in different states, urban versus rural. Could you touch on how your experience has been practicing across those settings?
Okay, yeah, that is a good question. So I think that there's definitely a difference in how one practices in the community, particularly if it's rural versus if it's in urban. I think namely the findings would be that for the most part, the urban practicing physician has a lot of phone a friends, and there is a lot of possibility to refer people. And then you develop a referral relationship with other physicians. And I think that can be quite beneficial because patients can get in sooner if the one doctor feels that it's very necessary, and communication is more open. So I think that's one of the things, and most of the urban settings are going to be referral centers, which are centers that are larger hospitals that take in the community cases that were sort of upgraded because the smaller community hospitals may have not had the capacity of whether it's imaging or interventional radiology, or even the specialty capacity. So some hospitals don't have urology coverage. They don't have a urologist, which is a surgeon of the kidneys and ureteral system. So that's the one main difference, is the referral center. There's that kind of relationship that you develop with other specialists and other physicians. The other thing is probably maybe less as a physician you see it, but there's a little bit more consumerism, I think, in the larger cities, where a patient can, not always feel like, oh, they're stuck with seeing a doctor. I'm kind of taking it from the patient perspective, but the idea here is that sometimes you can kind of, narrow in on what doctor is that you think may be the best one that you gel with. And I do want to make a good case to that, because I'm not a doctor for every for every patient, and nor is anyone. And so so that I think sometimes helps. Whereas in more rural areas where there's less doctors per patient, and that's actually a significant problem, by the way. There is a shortage of physicians in the rural settings, and that's quite a noticeable difference. Part of it is that people like to live in the cities. Salaries are actually lower in the cities compared to the rural settings, and sometimes those enticements still aren't enough to get people to come. Whereas a rural doctor often tends to be a little bit more of a jack of all trades. Sure, there'll be some specialists in those settings, but oftentimes the specialists stay in the cities. And so the rural doctor tends to have to cover their bases and do other procedures, or they also learn their kind of pool of other providers to refer to. I'll give you an example. I was working in a small town in McMinnville, which is a small town in Oregon. And we had a patient who came in and had a skin issue. And I called the dermatologist, and the dermatologist wasn't working that day. They only worked 3 days a week. And now if I called Portland, which is the big city from McMinnville, about an hour away from McMinnville, I probably could have got that person in within a few weeks. But even then, it's not fast enough. And so I said, well, I can do a procedure here. We have all the tools. And so that was like a decision I had to actively make, because after my training, I hadn't done too many procedures with infectious diseases, except for chart biopsies. But so I did a biopsy, and it was a good thing because the patient had a spreading varicella infection. And so sometimes you kind of have to take the bull by the horns and decide what you're going to do. Worst case scenario, if in patients where you feel like it's over your head, you send them to the ER in those settings. But I think those are the main differences.
We had a student who was actually in the Portland area or near that, and they were wondering if they could possibly get in contact with you. Do you mind just resharing your contact screen again, the one with your email and your contact information?
Yeah, they can email me. Right now I'm working in a prison setting, which that's got a lot of stories there. That's a fascinating environment. And that's the other thing, is when you have when you're more flexible, and also you kind of give yourself a few bonus days, 1 or 2 bonus days to do, you can do different jobs. And I think that has been my remedy, and hopefully resilience, not just like a simple remedy, but my resilience to burnout. Because I think it kind of ebbs and flows sometimes based on workload. And I think for me, the COVID-19 pandemic was kind of a little bit of a pusher towards that. But yeah, you can reach out to me through my email, and we can provide some additional kind of one-on-one if you have specific questions. Like I said, I can give a short meeting with you, and we can do like a Zoom call. Or if you're interested in shadowing, I'm moving on to a position with a clinic, and so there's going to be a greater likelihood that I'll be able to take you into shadowing.
Yeah, I just wanted to quickly ask to clarify. I see the listed email has 710. Is that the right one, or 710 not included in your Gmail?
Oh my gosh. Okay, you're right. Let me get this changed. Yeah, so it's just yhfcirino@gmail.com. Thank you. Yeah, I have several emails, and this was the one that I was able to get rid of the 710 out of. The other ones are Cirino 710.
No worries. What I can do is actually I'll send in, if you don't mind, I'll send in your email in the YouTube chat so people can just copy paste instead of reading it off letter by letter. Are you fine with that, or?
Oh yeah, it's there now on the YouTube. But yeah, sure, that's fine.
Sounds good. Yeah. Well, feel free to get in contact with Dr. Cirino. Just a great physician. We're happy to have you on board here. A few more questions that we wanted to go through. One of them being that there's a few stereotypes from specialty to specialty, but infectious diseases is really known to be very detailed in terms of note taking. In that
Mhm.
beginning process of your years training as a fellow in infectious diseases, what was the learning curve like with getting used to that detailed note taking?
I think I chose the right specialty because that was kind of how I was already. I think a lot of times the specialty you choose, let it be something that you have a passion for. I did my undergrad training in microbiology, and I just was so fascinated, even as a child, with microscopes and all of that. So I think it was closer to that kind of inner passion where it lies. But anyways, yeah, I am very detail oriented, and I'm the kind of guy that's a bit stubborn. I'm the kind of doctor that's a bit stubborn, and I'll go back and review the chart. I'll go back and talk to the patient. Not like an inquisition, but it can be. Yeah, I like to go through and really understand the history, following Osler's notion that the patient is telling you what's wrong with them. So I think in some ways, sometimes the profession you choose, you should let your skill set help guide you. There's a little kind of an intuitive or intuition to that. Sometimes people who like to do procedures, right? Maybe they want to be a GI doctor. They really enjoy gaming or something. We can go on and on with that, but like dermatologists, maybe someone had a specific history with acne or something growing up, or they had a skin condition, maybe they were hospitalized for, and that goes on. But I think for the most part, the adjustment wasn't too bad. What I think the greater adjustment was for me is because I like to get into things, and I like to do procedures, I like to do things. I had to be more it's a little bit more cerebral. And so, and also I kind of had to let go of the whole patient in a way, yet I still needed the whole patient, right? Because infectious disease is all systems. But let's say, someone has a pneumonia. I don't have to worry as much about their diabetes at the time. Nevertheless, I can't ignore that is a risk factor. So I thought for me, infectious disease was really complementary to being in what you would expect an internist to be, an internal medicine doctor to be. So that's why I chose it.
I was actually going to ask somewhat of a similar question. You mentioned earlier you were somewhat interested in psychiatry, and I'm sure maybe a few other specialties were involved in that. Is there anything else you'd like to add to the process of narrowing yourself down to choosing infectious diseases?
Well, I kind of gave you the general on sort of some of the ideas you can use to narrow down what you might be interested in. I will want to say something that's really important. We do have a huge shortage of primary care doctors, particularly in rural settings. I was trained in a rural medical school setting, and their main initiative to becoming a medical school, that's Ohio University Heritage College of Osteopathic Medicine, was to churn out, to support, is a better word, more primary care doctors. So I do want to, ring a bell for that, because that's a great field. You can be a jack of all trades, and you can also develop a skill set of your specific interests. So I think that would be the one thing I'll say, is that you don't always have to think of it as what specialty am I getting into. But if you like all of them, you can decide not to choose a specialty and become a generalist. And that's why I included that slide on generalist versus specialist. I would say the way I did it was, every time I did a rotation, I considered myself, what would it be like if I were that specialist, or if I were that practitioner? So if I did my rheumatology elective, I would pretend like I were a rheumatologist. What would it be like to have that career? And I would say that sometimes people make decisions based on doing surgery. So like they really want to do surgery. So that could mean maybe they want to be an ophthalmologist who does real intricate surgery, or maybe they want to be a general surgeon, or a urologist, or a plastic surgeon, or a cancer surgeon. And so sometimes you can kind of decide based on what is it that you want to do. You want to get your hands on, be more of a, kind of in that sense, more of a skilled surgeon in that case, or do you want to be kind of more, thinking about the full picture of health and illness, and sort of looking at the full picture of a person, or looking at specific disciplines within that. That's internal medicine versus gastroenterology, rheumatology, cardiology. These are all branches. There's over 13 recognized subspecialties to internal medicine. And in order to become a subspecialist, you have to become a specialist in internal medicine to become a subspecialist. Otherwise, family medicine, is the other route to primary care, pediatrics. And then the pediatrics discipline also has multiple subspecialties too. And then, of course, OB-GYN, surgery that we talked about, multiple, whatever system has a specific surgeon. So just as a general, to summarize, Michael, I would say, kind of understand where you are. Also take a look at what is it that gives you the most passion as you're doing those rotations. Even do some role playing. If I were this type of person, how would I like the lifestyle? How would I like, being on call all the time? And so those can sometimes help you with your decision.
I'm sure putting yourself in their shoes would definitely be a great way, I guess the best way to go about things with that. Maybe just a last question to wrap up things. You've diversified your career past just being in the clinic, being an author, being a speaker, going abroad. I mean, for some people that might create a sense of discomfort, but what was the initial learning process like, or just the initial exposures like of getting yourself used to going beyond what a typical physician would do?
That's a really good question, Michael. I don't know. I think I kind of go back to the fact that I was never really completely convinced that I wanted to be a traditional doctor all my life, and just kind of retire at 75 and start, living everything I held back doing in my life. And, and that isn't to say that, the career isn't fulfilling. It is. To be a physician is quite a fulfilling career because you're dealing with people, and you're kind of dealing with really kind of the heart of the matter of issues of that can be life and death. And, that can also induce fright, induce fear in others. And so, it's kind of a neat way of looking at it, is that when you develop that skill set, you're essentially developing your heuristic, or almost like an intuition on helping a patient. Now, I sometimes consider myself a healer more than a doctor. I thought the osteopathic training was really helpful for me because I remember reading these kind of like, self-help and new age books when I was in my teens. I used to work at a library, and I saw these kind of cool pictures, and I got attracted to at least the covers. And so I started reading, and, it really kind of fit into me real well, in that kind of passion and that heart about, people who've been injured, people who've been in different ways traumatized. And, I think that kind of led me in the direction to become an infection doctor, where I was able to really, kind of treat a wounded person who received an infection, not always from their own doing, but sometimes being in the wrong place at the wrong time. But nevertheless, a lot of infections are related to behaviors. So I think it kind of gave me a real full circle. And so it made me think, I have practiced full-time ID where I was working in a smaller community, nevertheless a big enough town where it was just the main hospital. I was with two other ID doctors, and we were on call every 3 days, every 3 weekends. And then I started having kids, and I said, is this completely what I really wanted to when I got into ID? And actually it wasn't. I really was interested in being a tropical medicine doctor, and I really enjoyed the idea of research. And at some point, I was one of my research instructors in undergrad, he was trying to convince me to become a PhD or go into that direction, then become a doctor. And I thought to myself, well, I don't know, I might not be the most people person, but there's something about me that really wants to take me to people, to work with them. And also just to learn about how the body heals. I mean, that's the most fascinating part of it all, I think. How can you set the body into the place where it does heal? So I think it was just taking that chance and understanding that maybe my career really, and it goes back to the other question I told for the pre-med students, is really, take a little bit of take a little bit of opportunity and invite an invitation to curiosity about, you don't have to be that cookie cutter doctor. You can do other things in the realm of medicine, let alone you have to do other things if you want to, right? If you want to have children, if you want to have, and so you are not a doctor. You are you who happens to be a doctor. And so I just want to encourage everyone, kind of think of it in that gestalt as they work in their direction to becoming doctors, becoming tomorrow's doctor.
Well, I think that's just a great way to end off our session today. Thank you so much again, Dr. Cirino. This was such an enjoyable session. I think we covered really a great range of topics from your clinical practice, infectious diseases, osteopathic medicine, really the whole 9 yards.
Awesome.
I'm glad
thank you so much, Michael, for giving me this time. And I'm very happy to be here to discuss this thing for our future doctors. And I just want to continue. You can reach out to me if you have any questions, but definitely excited to see the new generation of doctors that you're helping along, Michael. And I really appreciate what you're doing too.
Yeah, I really do appreciate your kind words. And I mean, not from my only perspective, but I'm sure for everyone listening in, they can definitely say they took a lot from this. And just like you mentioned, for anyone who'd like to get in contact with Dr. Cirino, he had his contact screen up. If you want to just go back a few more minutes, in live stream to view, definitely get in contact with him. I'm sure you'd benefit a lot from getting in contact. And I believe you have your book, your website, so there's a range of resources there. For those listening in, those who might be new to the virtual shadowing format, we have quizzes at the end of these sessions so that you can receive credit for your attendance. So these sessions are usually based on the amount of time. For this session, it's going to be 1.5 hours that you'll be credited if you pass the quiz. This quiz will be, you must pass it with at least 60% or above, and it's now posted in the chat box. It's also available on our website under the virtual shadowing page. If you look at the box just above past shadowing speakers, you'll be able to click onto that and log on to our quiz. It's a Google form. It's going to be due at 11:59 next week on Wednesday, May 4th. And the following day after that, we're going to have our next shadowing session with Dr. Husney over ENT, or head and neck surgery, as usual, Thursday, May 5th at 7 p.m. Central. For those who aren't familiar with our schedule, we usually go by a weekly Thursday schedule at 7 p.m. Central. A few more notes about our quiz. Once you do pass it, you'll receive a certificate, and this will document your name, the speaker you shadowed with, so Dr. Cirino, and also the date and the time that you've shadowed with him. So that will all be included on the certificate. It's going to be sent to the inbox of the email address you list on the quiz. And if you have any difficulties with finding that quiz finding that certificate in your inbox, feel free to reach out over email or check your spam folder just in case. But again, thank you so much, Dr. Cirino, and I really thank everyone for joining us in today. It was a really